So my question here is like, this is the patient who got MR done for cirrhosis, and we see this lesion, arterially hyperenhancing, washes out and has some pseudocapsule. So clearly LR5. On subsequent scans, we do not see it. This is the first scan when we didn't see it, and there is yet another scan where we did not see it. So I know we call them not lesions, observations for a reason, because they can be arterial phenomenon, arterial portal phenomenon, and we may not see them. But does that also apply for LR5? Say if we say LR5 once, do we not see it the second time or the third time also?
There's a condition called vanishing HCC.
Okay.
And I had a case when I was a fellow, the lesion was much bigger than that. And it was, I mean, over 2 centimeters. And then we had a subsequent study and it was gone. And we're like, do we have the right study? Like, is this the right patient? You know what I mean? And we like
Yeah.
matched up other findings in the abdomen and we're like, no, it's the same patient.
Okay.
But the lesion was gone. So it's been
I've
described.
seen
It's
this
called
too, and I
vanishing
think it's like
HCC.
your body fights it off, like kills it.
Interesting.
I don't know if that's what happened here because this lesion looks smaller. So I would just be curious, like, for example, EVIS, right? Like it's really sensitive for HCC. So confirm it there. But because this one was smallish, at least at the one at the dome that you were showing earlier.
Yeah, but then the other lesion persists.
I was gonna say sometimes it's the phase of contrast, but yours looks like a decent phase and it looks like it's not really there. But your lesion is, the other lesion was so small that I would just like follow it.
Okay.
But yes, I agree with Nelly. They can disappear. Say IPMNs can also disappear, and like I think it's usually like just involution of the mucin, but I have seen that quite a few times too.
No, so my question is like, one lesion disappearing and the lesion at the bottom. This is again the prior first study. This is there, again LR5 washing out pseudocapsule. The bottom lesion persists and the top lesion just goes away.
That's fine. They don't like they often don't behave the same.
Dissociated responses can be seen, you mean?
Yeah.
Okay.
Start recording.
The management is not going to change. I mean, if the lesion that we're looking at is greater than 2 centimeters, the patient already meets exception for MELD exception, so it wouldn't change. The dome lesion won't change its course.
Sure.
Patient.
Thank you. Stomach lesion. Intussusception.
Yeah.
Yeah. Intussusception.
Like a lipoma or something. Oh, the mass. There's the mass. It's like a gist. What is it?
Exactly. So it's a gist. And the tricky part here is when you have a gist, you want to be able to tell them, like, do I think this is endophytic, exophytic, and is it involving the GE junction or not? Because if it involves the GE junction, sometimes that necessitates a total gastrectomy because it involves the vagus nerve. And so, in this particular case, it was luckily we had a prior that had a gastric protocol. So this is why one of the reasons we do the gastric protocol is we give fluid to distend the stomach so we can see the endo or exophytic nature. And you can see that it's mostly endophytic with this little exophytic component. So it's a dumbbell-shaped one, but mostly endophytic. Sometimes those can actually be resected endoscopically, or they can do a hybrid procedure. And then you can also see that like on this one nicely, you can actually see it does not involve the GE junction. The interface is here at the fundus. So that's just a teaching point of like always try to do the gastric protocol if you know you have a gastric lesion. And then these are the reasons why, endo versus exophytic. They ended up being able to mostly, like they basically went in endoscopically and put like stitches at the edges of where the base of this thing was. And then the surgeons came from the outside and like cut around there. So you can have a much smaller defect than if you were just like blindly resecting it. And then for GIST tumors, you can do, you don't have to do like the extensive oncologic resection that you do for like gastric adenocarcinoma. You don't resect the like 20 lymph node stations. You just basically can do like a small margin on it. And sometimes if it's too big or it's involving the GE junction, they can shrink it down with Gleevec, but in this case, it wasn't involving it. So we just resected it. Okay, this is a patient. with rectal pain.
Female patient.
Wow.
It's a male patient, yeah.
Is this tubo-ovarian abscess?
It's
What?
a male patient.
Male patient.
Do you have the sagittal?
Yep.
Long segment thickening of the small bowel with adjacent stranding. Is it lymphoma? Is it?
There's like this.
Oops. I don't think the sagittal is as helpful. Let me just go back to the axial for a sec. I'll show you, actually, I'll show you the coronal. It definitely looks like a low density
Like
inflammatory.
in the upper rectum, it's like kind of wrapping around the rectum.
Exactly. Yes. So yeah, it's basically, anyway, this was a severe proctitis. And this turned out to be gonococcal proctitis.
Ugh.
So I was looking it up in Radiopedia under proctitis. Actually, gonococcal and syphilis proctitis are two of the most common ones. It says that E. coli proctitis is uncommon, which I think is a little weird because I see, I don't know, I see proctitis not that uncommonly, but and it can get extremely severe like this. These are basically like intramural abscesses. They ended up going and doing a colonoscopy, and the mucosa was all actually completely normal. But they were able to do an EUS and then like basically drain these through the transrectally. They didn't like, I mean, another option we considered was going like transgluteal. Like you could go here, you always want to stay close to the sacrum so that you're not hitting the sciatic nerve. And, we thought about putting a drain in here, but often that will create a fistula through the gluteal muscles, and it also is very painful. So they were able to just transrectally drain it, give antibiotics, and the patient did well.
Wow.
Yeah.
So again, Lyrad's case, we see this peripherally enhancing observation. Eventually does not fill in. I don't know, like, should I call it LR-M or like technically it is LR-M, but it does not fill in, does not have a great T2 correlate, was not seen on diffusion either.
When you say it doesn't fill in, to me, it does look like harder to see on the delay than on the initial one. So are you sure it's not like filling in a little bit? And then the other thing is,
that's the most delayed one.
Yeah.
I always say watch it, see what it does.
So should I, like, again, I know I'm not a very big fan of labels. At times I just like go more descriptive, but like, should I say it LRM or should I just say like a lesion is seen, which is probably indeterminate, and follow it up?
I mean, to me, it has rim APHE.
Hmm.
I don't know that it even has to like fill in that much, like completely. So I think I would still call it like small LRM lesion.
Okay.
And like recommend 3-month follow-up.
Okay, that sounds reasonable.
And at least at our institution, if they're very small, that's usually they follow them anyway.
Yeah, exactly.
Like even your other one that was like potentially the LR5, and like obviously it has to be greater than a centimeter to even call it that, but like often when they're that small, they just follow them.
And it is okay, not like, would you not expect a T2 correlate?
I mean, it's nice, it would favor malignancy, but that whole liver is very heterogeneous, so I could see like not seeing,
Okay.
It is, it would be like much more reassuring that it was LRM if you saw the diffusion. You said there was nothing on diffusion, right?
Nothing on diffusion either.
Yeah. I mean, I think you could probably go either way here. You could say like, it has rim APHE, but no other features. This may be maybe early LRM or.
Okay, sounds great. Thank you.
So this patient had a APR for rectal cancer, low rectal cancer. And this is the immediate postoperative film. They're having a fever.
Is that just hemostatic agents or is that an abscess? Like, what is that?
That's the teaching point. So what do you guys think?
Like, did they retain, is there a retained foreign body?
The hemostatic plug, is it that?
So yeah, excellent thought. Like, is this just Surgicel? Looked in the op report, they did not use Surgicel. Like, they used a very small amount. This is actually something else that they did during this APR that turned into this.
They
Like a bag? Is like a retained bag?
Nope.
perforated some piece of bowel.
Nope. So anyway, they did an omental flap, omental pedicle flap. Sometimes they do omentum and sometimes they do a muscle flap. Have you guys seen that? Like where they flip up one of these thigh muscles into the APR bed?
Yeah.
Basically, it's like, you know, it provides not only space occupying so other organs don't fall down there, but it also promotes healing. But if the pedicle flap doesn't have like good vascularity, it can necrose. So this was a necrotic omental pedicle flap. I think I showed you guys a similar case of this a few weeks ago when the patient had a Whipple and they put a transverse omental pedicle flap and it also necrosed. So just something to be aware of when you have these large surgeries like APR, like partial hepatectomy, like when you remove half the liver, they often will put the omentum there to like be space occupying and promote healing. And when you have a lot of air in it, it's usually because there wasn't enough vascularity and it necrosed. They don't do anything about it. They just basically treat it conservatively. It can cause fevers, but it usually just kind of like resolves. It doesn't, you know, that doesn't mean this is all like gas forming organism or anything like that.
Remind me again when they do that for APR?
Here they do it a lot for APRs
Oh.
because yeah, and then sometimes they do the muscle part. So that's another, if you see this like linear kind of soft tissue thing, that can also mimic like a soft tissue mass, but it's actually just muscle.
Yeah, it's something we do regularly here.
It's something what you don't do regularly?
We do not do regularly
okay.
here. Yeah, routinely.
Yeah, I guess I'm not sure like what would make them do it in one situation or another, but maybe it's like how healthy the omentum is. I don't know. Okay, this is like a middle-aged female. Has this lesion in the liver. This is the T2. Free. Arterial. Not the best arterial. This was actually an EVIS scan, so I can show you. We had a post another one that was not an EVIS. This is the venous. This is the delay. And then I'll give you the 20-minute delay is this one. And then I'm going to show you the in and outs. So first of all, on this 20-minute EVIS delay, would you call this retention?
Not necessarily.
Yeah, I would not personally call this retention. I see that like there is this kind of like part here. Maybe there's a centrally necrotic part. Maybe there's this like little rim where it's retaining, but I would not really call that retention. And then I'm going to show you, this is the in phase. And then this is the out of phase. So there's
wow,
fat in it. Microscopic fat. So what do you guys think?
can you show me the T2 again? Sorry, I missed that. And no liver disease, you said?
No known liver disease. And her liver doesn't, it looks pretty normal.
There's another one too, right there in the segment 3. Or maybe that's just an overlapping structure. Oh, that's just a pylorus or something. Okay. Well, I mean, if no liver disease, when I saw the fat, what I was thinking about was the HNF1 alpha adenoma subtype. And what else things? I mean, HCC, but I think we use that. I mean, we think about that in patients who have liver disease typically.
Yeah.
Other fat containing lesions.
I mean, to me, microscopic fat is basically adenoma versus HCC. Macroscopic, I think about like AML, like
AML, yeah,
that kind of thing. But this was micro. Even though it was like dense drop, it wasn't like India ink. I just want to show you the arterial phase from the non-EVIS scan, which I think is a little bit better of an arterial phase. And you can see that there is like arterial phase hyperenhancement.
Is it angiosarcoma, flame-shaped enhancement?
And then washout. Oh, that's another good thought, but I don't know if I don't think angiosarcomas have microscopic fat.
No, they don't.
I think we've seen a case of FNH with microscopic fat, but this is a pretty pronounced amount of fat.
Yes, you can get fat in FNH, and especially if the background liver has fat, because it's like, disorganization of the same kind of fat, tissue. But I don't, this to me does not look like FNH. And then like FNH should have like usually a homogeneous arterial blush.
Yeah, this is
Not
too
like
ugly
this.
to be an FNH, yeah.
Yeah. So that was one of my teaching points actually, because it was raised like, oh, is this an FNH and is this, retention here? But I would say that this is not retention, or like not the classic retention of an FNH. And I don't even know why this is retaining here, maybe just because of some HCC elements. Anyway, in the end, this turned out to be a HCC. One of the other things that was brought up was that usually if there's fat, microscopic fat in an HCC, it's a well-differentiated HCC with a better prognosis. However, this one actually turned out to be poorly differentiated HCC with cholangiocarcinoma, mixed phenotype, and
Oh, wow.
sarcomatoid transformation.
Oh my gosh.
So
And
the
it's
patient actually ended
biphenotypic.
up, yeah, biphenotypic, really poorly differentiated. The patient actually ended up passing away, like, not shortly, like 6 months later. So yeah, it was just kind of a tricky one. But I guess like one of the things is just don't, like really, if to call an FNH, you really want it to look like FNH in all like most of the sequences, like nice homogeneous arterial blush, stealth on other sequences, nice retention on eovist. And then even though microscopic fat is associated with well-differentiated, this was a case where it was poorly differentiated. So I don't know. The other thing is you can get HCC, and like a lot of times like people are like, oh, well, it can't be HCC, they don't have chronic liver disease. But I've seen plenty of patients that have no chronic liver disease or history that just get de novo HCC. So
So I've withheld the history. This patient underwent a procedure recently, and I want you to focus in the right upper quadrant. I'll go slightly more posterior. What do you guys see?
I see a lot of fluid along the
abdominal wall, pleural
Yeah.
effusion, lots of edema around the kidney.
gallstones. Or where are those? Are those stones, and where are they? No, they're not in the gallbladder.
Where's the gallbladder?
Oh, are these
Drop
drop
stones.
gallstones?
Yes.
Oh wow, that's a lot.
So here they are in
When
the,
was the surgery? Oh, you said the patient's post-op?
yes.
Oh, okay.
So although this axial does not go as far inferiorly, but they were also found in the right paracolic gutter. I think I have the clinical image for this patient.
Did they say anything about, like, in the surgery that it was complex and the gallbladder ruptured in intraop or anything like
It
that?
did rupture. No, thank you for asking that. It did rupture, and they knew that there was a spillage.
Mm.
Do you guys see the?
Yeah. They probably tried to go grab them, but maybe couldn't get all of them.
Missed them, yeah.
And interestingly, not all dropped gallstones will give rise to an abscess, because we did see one, and then we read there is an AJR article. It says like, yes, dropped gallstones generally give rise to an abscess, but they may not always give rise to one.
I had a case where I think I showed it. It went kind of in this posterior subhepatic space, and then over years, like it started to develop this like granulomatous reaction, and like pretty extensive.
Yeah, I think that can do that, like sort of a chronic smoldering kind of thing. It can also drop down into the pelvis.
Yes.
So I mean, even though it might not lead to it, I think it's worth retrieving it if it has any complications, because it's just going to get worse if you don't.
True.
The tricky part is like here, for example, right now there's no inflammation, so we don't know what to do at this. You know, like, would you preemptively go in and take these out or just wait and watch?
Yeah, I don't know. If I was a patient, what would I do? I mean, I guess if I was young and healthy, I probably want them to take it out, but that would be crazy just to go under anesthesia for
Yeah,
to have
there
those
are
stones
quite a
removed.
few of them.
Yeah. And some of them are in a tough location too to try to dig out.
Mhm.
Yes, that's why we're not surgeons. Let them.
And since we are talking about gallstones, I want to thank Dr. Sekhar because I was trying to find cases for her for gallbladder previously, and for whatever reason, I saw a lot of cases which were cholecystectomy in my list. And then most of those patients had RCC. Like at least I saw 20 patients and at least 8 or 9 had. So it did not look like, probably it was by chance. And I went online and I read that just having gallstones has an association with other cancers, including RCC, which was very surprising. There's a
Hmm.
recent article, I think, in one of the big journals.
Wow, I had no idea.
Let me see if I can pull that
Is
up.
it maybe just like all related to like bad eating habits?
That's possible, but I don't think they said that.
Or like, yeah, like different toxins that are being then turned into gallstones, but also like increase your risk for other malignancies. Because obesity is a risk for both of them, RCC and gallstones.
Yashant, the view is okay, perfect here.
Sorry. Yes. I don't know if it opens here or not. Our findings provide solid evidence for compelling need to diagnostically rule out kidney cancer before and during gallbladder removal, to prioritize kidney cancer screening in patients undergoing cholecystectomy in their 30s, and to investigate underlying mechanisms linking gallstones and kidney cancer in future studies.
Whoa, that's really interesting because we don't do any kind of like for example, a lot of people just get ultrasound, get diagnosed with cholecystitis. They don't even get, for example, an MRI to look at their biliary abnormalities.
This is
Wait,
very
can you go down? Sorry, scroll down. They said they saw kidney cancer 6 months after, so in the results section. So kidney cancer risk was increased in the first 6 months after cholecystectomy. So like, did they not see it on imaging at the like pre-op? Like, is it newly developed kidney cancer or is it kidney cancer that was there? Because kidney cancer is usually, not the most aggressive cancers. They don't like show up in 6 months.
That's a good question. I'm not sure about that. I'll have to dig more.
It's interesting though that they say it's not, they say like this 18,000 patients in the United Kingdom, it showed a causal effect.
It should be associated because they're not.
I
Exactly.
would assume association, not causation.
But it
Yeah,
says literally here, it says causal effect.
I don't know. I think
Yeah.
the
I think it might be
conclusions that they're
coincidental, like they both have the same risk factor or something, but I don't know.
so hold on, and they don't have a comparative group, right? Like, so the starting group is people who had cholecystectomy. What about people who didn't have cholecystectomy, who had gallstones, and then look at the prevalence of kidney cancer in that group? Like, there's no control group.
Probably
Well,
they
he
did.
says the non-cholecystectomized patients are 16.6 million people. It is retrospective, but there is a comparison group.
So what are they saying? So they're saying kidney cancer. So the kidney cancer risk is higher in people who got cholecystectomy compared to those who didn't, in both groups that had gallstones. So does that mean like cholecystectomy increase the risk of like kidney cancer, or the prevalence like just having gallstones increase the risk of, you know what I mean? What's the comparison group? Like what I would do is have a group that had start with people who had gallstones, right? One group or even just a general cohort, like non-gallstones. Like I don't know. I think it comes down to what the comparison group was.
It
So
does here mention some comorbidities like smoking and diabetes.
it
I
does. Sorry, go ahead.
No, maybe we should I'll read this and then like
Yeah,
in more detail
agree.
and discuss that next time.
Sure. Thank you.
But yeah, interesting, very provocative.
Okay, so okay, so my colleague Kumar Chandrasekaran we're in the middle. We're in the middle of a study, retrospective study to test out Nicole's workflow, and so I have a case from that. It was such an awesome learning experience, and I feel a lot more confident and comfortable now with atypical uterine masses now. Anyways, I wanted to share one of this case that was part of that retrospective review. So we're interested in this one here. This one doesn't have post contrast. It was an older study, but I think I think the main point is still valid. So that's right here.
Wait, it's definitely not affiliated with the endometrium. It's in the myometrium.
We have surgical path, so we know what this thing is, and it is a myometrial lesion.
Okay. To me, already it looks suspicious. Like I don't like the evil gray, and I don't like some of the borders.
And the T2 signal is kind of high, right? Like, and then here's a diffusion. It does measure down to under 900. And this is right here. So this was a cellular fibroid.
Algorithm didn't work here.
No, actually, many times on these atypical masses, the algorithm does not work. And here, I see what you're saying about, like here, for example, I don't know if it's just a resolution or but maybe it's herniated into different things. But what I learned, at least from reviewing the 30 or so studies we had over like 120 cases, but each of us just reviewed like 30 or 40, and is LMS are big and they are ugly. Like you had mentioned before, Aarti, like there's lobulations, like sometimes you get the disruption of the capsule, or if I don't know if there's a capsule, but the margins. And they have very heterogeneous T2 signal, like heterogeneous T1 and post contrast. But if you have um, this I hear you, because the kind of maybe even posteriorly you don't really see the margins as well. But if you did, and we saw just this T2 signal, which would meet that T2 hyperintensity guideline from Nicole, and the diffusion certainly does too. Because it would go down the LMS, but it very commonly cellular fibroids look like this.
I was gonna say, so heterogeneity is not in the algorithm.
No, it's not, and the margins aren't in the and so cellular fibroids, this is one of a handful of cases that I can share. They restrict, right? So they meet the T2 hyperintensity. This doesn't have contrast, but many of them enhance when we do have contrast. And then it restricts a lot. So it meets both the high signal, like higher than endometrium on high B value, and then ADC less than 900. And they're cellular fibroids. Yeah. So that's probably going to be most of the ones that the work that decision tree fails.
Nice.
But if they're not ugly, if they're not big, if they're not heterogeneous, if the margins are lobulated, irregular, all of that, then it's a fibroid. I mean, cellular fibroid. So now we're starting to do biopsies on these cases. Because it's just the pretest probability for LMS is still very, very low, even with these atypical features, to suggest not non-typical fibroid. So it was a fantastic study, and now I feel a lot more comfortable and confident, like just saying these atypical looking things are cellular fibroid.
So if you got this now, you would say most suggestive of a cellular fibroid.
This one, I think here, like the margin, I agree with you here. I would still say it's suggestive and maybe recommend a biopsy.
And then you guys are doing like percutaneous biopsies, not transvaginal.
Yes, correct. Yeah.
Cool.
And we're working with our gynecologists because they're still concerned about seeding. So we have some work
With
to do to
coaxial
synergize.
technique, for sarcomas, for example, we biopsy them all the time here,
Yep.
and our surgeons are not really that concerned anymore. With coaxial technique, it's like much,
Yes.
much more rare. But
And there's been studies that like looks at it, and the incidence of seeding is like almost negligent.
yeah, same thing for RCC.
Yep.
Very cool. We would love to see more of those cases that from your study.
Awesome.
Yeah. Okay. What do you guys think?
Emphysematous philo. No,
Very
but there's a
good.
catheter.
Yeah, so it looks
Wow.
funny here, and I think maybe I don't know. We were like saying we might have thought it was like bowel with pneumatosis. One clue is that there's a nephrostomy tube in here. This was actually after the CT, but I'll show you the CT now. And you can see it's extensive
Wow.
emphysematous pila. And then these often get treated with multiple drains. So this one the patient ended up getting a nephrostomy tube and then a nephrectomy, but there's this whole grading system depending on how much air is like within the parenchyma, how much is outside the parenchyma, and then how the patient is doing. If they're relatively stable but like they're sick but like still stable, you often can put like multiple large bore drains in here until they're like, fully stabilized, and then go for the nephrectomy. But sometimes if they're really sick, you have to go for an emergent nephrectomy.
So this elderly gentleman has soft tissue thickening of the gallbladder as well as additional soft tissue at the splenic hilum. This worsens over a period of time. He does also have like gallstones, and that's how it looks on ultrasound, although not diagnostically very great, but just thickening of the gallbladder wall.
So it looks atypical for gallbladder cancer because that mucosa on the ultrasound looks pretty good. It's almost like some submucosal process. I feel like you actually showed us like an IgG4 case that looked like this, but normally I wouldn't bring that up. And then show me the spleen again. So what connects gallbladder and spleen?
Submucosal process?
Yeah, like lymphoma.
Yes, it's a gallbladder lymphoma.
Oh, wow.
Wow.
And this patient also had few foci, tiny ones in the bones as well. So not a primary one, but multifocal. And it was cholecystectomy was done. It was DLBCL subtype.
Wow. Interesting that it's also narrowing the lumen, but I guess
I'm not sure if it is really narrow. Maybe, yes.
Or just like not, yeah.
It's not fully distended, so.
And no other lymphadenopathy though.
No.
Wow. So this patient had ulcerative colitis and a total proctocolectomy with an end ileostomy.
Sorry, what was the reason again?
Ulcerative colitis.
Oh, UC, okay.
And then has a complete resection of their colon and rectum with an ileostomy.
Is that all soft tissue or like, at the stoma site?
Yes. So all of this is sort of like fungulating polypoid soft tissue. Any thoughts on what kind?
What was the history?
Ulcerative
UC.
colitis.
So same like adenocarcinoma?
Good thought. So this actually turned out to be squamous cell carcinoma. And I looked it up. UC patients do have a higher risk of getting squamous cell. It's usually of the anus. And then anybody with an ileostomy or like a chronic stoma has an overall like increased risk of getting squamous cell around the stoma site just because of the chronic inflammation. So I think in this case, this might not really be related to the ulcerative colitis. I think it's maybe just related to like chronic inflammation, but then it became really florid and turned out to be poorly differentiated squamous cell carcinoma. It spread really quickly. They wanted to actually like resect the abdominal wall here, but it was like spreading so fast that they basically like couldn't get to it. And then the patient ended up passing away.
Wow.
But I just thought it was, yeah, very extreme example of like a big squamous cell of the, basically the stoma site in the abdominal wall.
Yeah. Yeah, so is the reason we get Marjolin's ulcers, which are burn ulcers and undergo squamous cell degeneration.
What cells? Burnal cells?
Squamous, like marginal ulcer is like when there is burn over a period of years, that burn site will undergo degeneration, it will become squamous cell carcinoma.
Got it. Marginal ulcer doesn't always mean it's squamous cell, right? It
No.
could be an ulcer, right? Okay.
Yeah.
Yep.
Yes, in a bit. I want to share a companion case for your pyelonephritis, just showing pyelitis.
Sure.
And the reason is because pyelitis can be treated medically. Pyelonephritis needs surgical intervention. So this is a case of emphysematous pyelitis. Air is only limited to the collecting system, the pelvis, and renal cortex and the parenchyma is all okay. So it's pyelonephritis, emphysematous, which needs surgical, but pyelitis and even cystitis, both can be managed medically.
That's a really extreme case though. Like look at all that bubbly air. But did well just with medical management, you're saying?
Yes.
Yeah. Cool.
This is another one of the atypical fibroid cases. And here, this is not as kind of pronounced as the other case that we showed, but there's T2 high, intermediate high signal in the mass. And then the contrast, there's enhancement, but not as enhancing as, for example, the myometrium, but there is enhancement. And then the diffusion, I think the diffusion is where it might be a little bit iffy in terms of whether it meets criteria or not. Oh, this is an older study, so we don't. But anyways, it is higher in signal than the endometrium. And then on the ADC, some areas I can get it to be under 900. Most of it is in the mid 900, but some areas I can get it to be under a little bit, maybe here. So this is borderline, but as I reviewed all of these pathology proven cases, like this would be like for me just benign. Like I wouldn't even go down the LMS track. Like this is benign, even though the LMS track might kind of take us down that way.
Can you blow up the T2?
Yeah.
Okay.
And this was a cellular fibroid.
Yeah. It's funny because like even though this one is more heterogeneous than the other one, I would say that this one, it almost has like an organized heterogeneity to it. So I see what you're saying. Like this now is striking me as like more of a fibroid, not like the heterogeneous, like
Ugliness.
necrotic ugliness that you would expect from an LMS.
Yeah.
Very cool.
Cervical cancer.
Okay, excellent. So this is a high-res T2.
But it's going into the uterus, like it's like there's extension into.
Yes.
Do you have the sagittal?
Oh, one sec. So the this is that evil gray T2.
And then the parametrium is also, there's
exactly.
invasion.
So it's involving the parametrium, and it is involving the like lower endometrium, lower uterine segment.
Yeah.
So this is cervical cancer. And then we got a full abdominal.
Pancreas looks bad. Why is the duct so dilated?
So the pancreatic duct is dilated.
All the way to the ampulla. Oh, there's something.
Actually, they had presented with jaundice, and so now by this point, there's in place.
There's a mass right there.
Yeah. So what would you guys say about this mass? I can show you.
EUS.
Okay.
I mean, if they don't have just, I mean, do the regular workup with IgG4 and other mimics, but the patient will eventually need an EUS.
Uh-huh. So there it was. So, I mean, this is, I guess, more of an academic question, but do you favor this to be a pancreatic cancer? Do you favor it to be a cervical cancer, Matt?
Cervical.
Oh, I don't know. Do you have the diffusion?
Mm-hmm. And
Is it,
I
is it
did look up
hypoenhancing?
Okay, I think I have.
here, right there. It's
Okay,
restricting.
it's a lot. Yeah. Oh, yeah. Look
Okay.
at that.
It's definitely restricting. And then I did look up, although I'm nowadays feeling like anything you look up you can find, but I looked up and there is like a association between patients who get pancreatic cancer and cervical cancer.
Yeah, I don't think this is a Met. I think
This
it's
is
because I don't see adenopathy. I don't see like
Yeah, I can show you
other
this is
local
aortic
staging
cable node.
issues.
Yeah, aortic cable soft tissue. Yeah,
here.
yeah,
That could just be tumor extension from the
yeah.
like a primary pancreas.
No, I agree with Dr. Chan. Like, yeah, sorry, I mean to say it is like dual malignancy because pancreatic met, even if they're big, they hardly cause ductal dilation. In fact, there was a paper I read, I think 2 years back. It said like adenocarcinoma will be quickest because it comes from within the duct, so it causes ductal dilation, but met usually does not.
Oh.
And even if it does, it is like, very mild. Contrary to
More like
what,
Mass Effect. Yeah.
yeah.
Yeah, so I was favoring
makes
this
sense.
might be a separate pancreatic primary. I was looking up like you can get both. There's like, Occam's razor, like everything is tied together, like all the diagnoses are related to one thing. And then there's Hickham's dictum, which is patient can have like multiple different diseases. And so I was kind of going down like Hickham's dictum, like they can have two separate primaries. Anyway, this was biopsied and it was a cervical cancer squamous cell carcinoma at Met.
Wow. So did they have adenopathy elsewhere?
Well, actually what you were saying, Yashant, like all of this stuff was also squamous Mets. They did get a PET. Let me try to pull that up without.
Tissue's the issue. See, like
I know, but we always try to like give oh no, sorry, we have there's no PET, sorry. But yeah, they're
the more and more I see and the more experience I get, like the more and more humble I become. Like, and rather than like this is this, I say this is probably this, but it could also be this and this. So like make sure it's not this and this. Because
exactly.
oftentimes you get proven wrong,
And I think you can even put that in the report. Like, for example, like say there's an infiltrative renal mass and it's invading the IVC or whatever, right? Like, and so our urologist will ask us, like, is this RCC or urothelial? And it's like, at this point, I've actually seen both do this. So I
that's
think
exactly right.
that's
You
more
biopsy.
typical to invade, however, occasionally urothelial can do this and, consider a biopsy.
Yes.
So yeah, that was this.